Hello everyone, thank you for joining me today. My name is Elton from the Physiotherapy Department of PYNEH. I am excited to share my research on the role of body composition in knee pain, gender-specific insight for the SAY program. The SAY program includes 4 key components: screening, assessment, fast check, and education. It was established in 2008. This annual plan is not only ongoing, but also be enhanced starting in 2024. We have recently incorporated allied health support into a specialized outpatient service, including face-to-face physiotherapy triage. Due to the long waiting times for routine case, a daughterly collaborative model for physiotherapy triage and early intervention has been developed. This model is designed for new orthopedic patients with non-acute MSK condition. The aim is to optimize patient care and improve overall outcomes. This is our overall care model. Our goal is to provide timely medical consultation and early physiotherapy intervention for our patients. With early intervention, we can prevent disease chronicity and reduce the waiting time for the first consultation. We conduct telephone consultation using questionnaires and CMS screening, followed by face-to-face triage to ensure that the process is safe, effective, and efficient. This other health integrated model of specialized outpatient service enhance the patient journey by facilitating appropriate and timely treatment. After the face-to-face triage, patients identified with red flags can be fast-tracked to P1 or P2. In contrast, other patients will receive early physiotherapy intervention. Some criteria indicate a fast track to joint replacement follow-up, including severe functional limitation that significantly differ from their premorbid status, weapon deterioration within 1 year, and severe knee deformity. At this stage, we can suggest and discuss the consideration of total knee replacement. For patients with better knee condition, they will continue physiotherapy for optimization while waiting for their routine follow-up. A key part of the program is assessing body composition using bioelectrical impedance analysis to measure skeletal muscle mass, body fat, and waist-to-hip ratio. These factors relate to knee pain and function according to previous studies, but research on how gender is different in these relationships is limited. This is the gap we aim to address. Our study aims to examine how gender influences the relationships between skeletal muscle mass, body fat, and waist-to-hip ratio regarding knee pain and function. This will help to inform the development of gender-specific strategies and guide the design of target physiotherapy programs. We conduct a cross-sectional study with 100 patients referred to the SAY program for chronic knee OA. To assess body composition, we utilize bioelectrical impedance analysis, also known as in-body, to evaluate skeletal muscle mass, body fat, and waist-to-hip ratio. The percentage of skeletal muscle mass and body fat were calculated based on the patient weight. For pain intensity, we use the NPRS and the Knee Injury and Osteoarthritis Outcome Score pain subscale. A higher Q score indicates better outcomes. Functional ability was assessed using the Q score physical function subscale and walking tolerance. To analyze the correlation between body composition and with the pain and the functional components, we employ a correlation test in male and female. Among the 44 male participants, the FA skeletal muscle mass was 47.8, body fat was 30.8, and the waist-to-hip ratio was 0.9. Among 66 female participants, the FH were 32.9, 37.6, and 0.88. For correlation in male, we find that skeletal muscle mass percentage demonstrate a significant negative correlation with the LPRS. This suggests that a higher muscle mass is associated with lower pain levels. Furthermore, we find significant positive correlation between skeletal muscle mass percentage and the Kuhl's physical function subscale. There were also significant positive correlation with walking tolerance. This indicates that greater muscle mass contributes to improved functional performance. For correlation in female, the waist-to-hip ratio was positively associated with the NPRS and negatively associated with the Kuhl's pain subscale. This means that a higher waist-to-hip ratio correlates with higher pain levels. Additionally, we find a significant negative association between waist-to-hip ratio and the Kuhl's physical function subscale, as well as with walking tolerance. This indicates that a higher waist-to-hip ratio is linked to reduced physical ability. This might highlight the importance of consider gender when evaluating the relationship between body composition, knee pain, and function in patients in NEOA. For males, skeletal muscle mass is a critical factor in reducing pain and enhanced functional performance. For male, a lower waist to hip ratio is associated with lower pain and increased physical ability. Gender-specific management strategies may optimize functional progress and enhance treatment efficacy for patients with NEOA. While our study provides valuable insight, it is essential to acknowledge several limitations. First, the cross-sectional design limits our ability to establish causal relationship between body composition, pain, and function. Longitudinal studies are needed to explore how this relationship evolves over time. Second, although our sample size is adequate for preliminary findings, it may not capture the full diversity of patients with NEOA. Therefore, a larger sample size is recommended for future research. Our research suggests that future studies should focus on the effectiveness of gender-specific strategies in reducing NEOA symptoms. For males, interventions that promote muscle gain, such as resistance training or neuromuscular stimulation, could be beneficial in improving muscle mass and reducing pain. For females, strategies emphasize weight management may help address challenges associated with a high waist-to-hip ratio. The SAFE program provides early intervention to optimize patient condition and enhance the overall journey. Our study offers insight into the significant correlation between body composition, knee pain, and functional ability, particularly when considering gender difference. Understanding these dilemmas is important for developing gender-specific treatment protocols and further enhance the SAFE program. Locomotive syndrome is common, especially in aging population. Optimizing knee pain management in public health is essential to maintain mobility and prevent comorbidities related to physical inactivity. In conclusion, we aim to develop a gender-specific protocol within the SAFE program to improve our patients' outcomes and quality of life. That's the end, and thank you all for your attention.